My name is Dr Stephen Pillinger. I'm a colorectal surgeon here at the Sydney Adventist Hospital. Basically, colorectal surgery is, in one word or one sentence or phrase, is problem solving in the abdomen. We virtually deal with any bowel problem from below the stomach to the anal canal. Most of what we deal with are two very common conditions in Australia. One is colorectal cancer, which is the most common internal malignancy affecting both sexes in Australia. Unfortunately, it doesn't get the press of some of the breast cancers and prostate cancers, but if you are going to have a cancer in your household in your lifetime, it's going to be a colorectal cancer. So it is an enormously important condition, and we treat all of those. We also treat diverticular disease, which is a disease which leads to a lot of morbidity, a lot of suffering, a lot of pain, and a lot of hospital admissions for a lot of people in Australia. With our type of diet and lifestyle, unfortunately, we are very susceptible to diverticular disease, and as we get fatter and type 2 diabetes becomes more prevalent, the problems that you encounter with diverticular disease are quite enormous. And those are the sort of conditions that we deal with. But really, any intra-abdominal condition will present to us first. We may then narrow down on the diagnosis and involve colleagues who are in different subspecialties, but pretty much when you have an acute problem in your abdomen, people will think of us first. Well, one of the things with going to medical school and watching TV shows is you see all of these cool tools that people use when they're doing colorectal surgery, but really the key to any medical specialty is going back to basics. Taking a good history and performing a thorough physical examination will give you the diagnosis 80 to 85% of the time. Then it's the judicious use of investigative tools and making the right decision in terms of operation. Really, back to basics is the most important part of any surgical practice. So history, examination, then from my specialty point of view, we often use tools such as CT scanning, MRI scanning, endoscopy, colonoscopy, diagnostic laparoscopy sometimes, and then obviously surgery. Surgical tools that we use in colorectal surgery, with a lot of emergencies, there's still a big role for open surgery, particularly with obstructed bowel. Obstructed bowel gets very big very quickly and causes a lot of pain, and often there's a risk of bowel perforation. That can be very difficult to appreciate with minimally invasive techniques, and often impossible to obtain enough space within the abdomen to work safely in a minimally invasive fashion. So open surgery still has a very big role in the emergency setting. More and more in the elective setting, for example, in my practice, 90% of what I do is minimally invasive surgery, and 10% is usually emergency surgery, where we use an open technique. So most of the time we're using more and more advanced tools to provide a better and better experience for patients, safer outcomes, and overall a better surgical experience. The most common question I get asked when patients come to see me in the room, it's often a very daunting interaction for a patient. When you're coming with, as my wife says, a bottom or tube problem, it's often very confronting and embarrassing, and most people will ask me, why do you do this? And my answer is unchanged in 20 years. It's because we can do a lot to help people. With colorectal cancer, we can cure most of our patients, and we can help just about 100% of them. There's not a lot of cancers you can say that about, but the most exciting thing about what I do is that most patients will be better once they've been through their treatment with me.